Management of Endometrial Hyperplasia, Royal College Green Top Guideline number 67. Part 4. Special situations with endometrial hyperplasia. First situation is fertility and endometrial hyperplasia. Disease regression should be achieved on at least one endometrial sample before attempt to conceive, as a hyperplastic endometrium may predispose to infertility. An early referral for fertility specialists can be offered. Obese women should aim for a body mass index of less than 30. Assisted reproduction may be considered as the live birth rate is higher, and it may prevent relapse compared with the women who attempt natural conception. A hysterectomy should be recommended to women with atypical hyperplasia once fertility is no longer required because of the high relapse rate and the potential for disease progression. Second situation is hormone replacement therapy and endometrial hyperplasia. Systemic estrogen-only hormone replacement therapy should not be used in women with a uterus. All women taking hormone replacement therapy should be encouraged to report any unscheduled vaginal bleeding promptly. Women with endometrial hyperplasia taking a sequential hormone replacement therapy preparation who wish to continue hormone replacement therapy should be advised to change to continuous progesterone intake using the intrauterine system or a continuous combined hormone replacement therapy preparation. Women with endometrial hyperplasia taking a continuous combined preparation who wish to continue hormone replacement therapy should have their need to continue hormone replacement therapy reviewed. Discuss the limitation of the available evidence regarding the optimal progesterone regimen in this context. Consider using the intrauterine system as a source of progesterone replacement. Third issue is breast cancer and endometrial hyperplasia. Tamoxifen is a selective estrogen receptor modulator that inhibits proliferation of breast cancer by competitive antagonism at estrogen receptors. However, it has a partial agonist action on other tissues, including the vagina and the uterus. This estrogenic effect may promote the development of fibroids, endometrial polyps, and hyperplasia, and increase the risk of endometrial cancer. Women taking tamoxifen should be informed about the increased risks of developing endometrial hyperplasia and cancer, and the risk increases with both dose and duration of treatment. They should be encouraged to report any abnormal vaginal bleeding or discharge promptly. Aromatase inhibitors inhibit estrogen synthesis in the peripheral tissues and have a similar tumor regressing effect to tamoxifen. Women taking aromatase inhibitors should be informed that these medications are not known to increase the risk of endometrial hyperplasia and cancer. There is evidence that the intrauterine system prevents polyp formation and that it reduces the incidence of endometrial hyperplasia in women on tamoxifen. The effect of intrauterine system on breast cancer recurrence risk remains uncertain, so its routine use cannot be recommended. How should women who develop endometrial hyperplasia while on tamoxifen treatment for breast cancer be managed? The partial agonist action of tamoxifen in the genital tract is associated with an increased risk of endometrial cancer. The need for tamoxifen should be reassessed and management should be according to the histological classification of endometrial hyperplasia and in conjunction with the woman's oncologist. Last issue is endometrial hyperplasia confined to endometrial polyp. Endometrial polyps are discrete overgrowth of the endometrium, and atipia may be restricted to foci within the polyp. Complete removal of the uterine polyp is recommended, and an endometrial biopsy should be obtained to sample the background endometrium. Subsequent management should be according to the histological classification of endometrial hyperplasia. Thank you for your attention.